This is Dr. Seth Gamrad from USC with arthroscopic double row rotator cuff repair. So here on a coronal view MRI, you can see a tear of the supraspinatus tendon retracted to the level of the mid-humerus without atrophy. And when we start doing the diagnostic arthroscopy from the undersurface of the rotator cuff in the beach chair position, we see this rotator cuff tear. Now we're in the subacromial space. You can see good mobility of the tissue, but we'll mobilize it even further. What I like to do is place a traction stitch first and then use the shaver and the heat probe to release any adhesions. So you can see there's a nice adhesion between the supraspinatus and the roof of the acromion. We'll clean that up with a heat probe. And what we're left with is a pretty decent size 2 by 2.5 centimeter crescent-shaped rotator cuff tear. Now, in this setting, I think it's important to do an acromioplasty. This is a young man with early onset rotator cuff repair, and that's largely due in this scenario due to impingement. So we'll burr out that acromial spur. Then we'll take the heat probe and start to prepare the greater tuberosity. So we'll clean off any soft tissue and then just roughen the surface so there's a little bit of bleeding. I like to start out with a posterior anchor. Viewing from posterior, placing my posterior anchor first. And we'll insert that anchor into the posterior aspect of the greater tuberosity. Twist in this biocomposite anchor. Now, each suture anchor is going to have 4 limbs of suture, and we're using a suture passing device to form horizontal mattress stitches. Once we pass those first 4 sutures, we'll go ahead and insert the anterior anchor. Another 4 sutures, and in this anterior passage, we like to really try and avoid that biceps tendon. We don't want to tether it into our repair. So we passed all of our sutures, 8 in total, to form 4 mattress sutures. Check and make sure we like the positioning of all these sutures. And we'll start to tie these down one at a time. Now, I don't like to use sliding knots in this scenario because it'll oftentimes cut through this tissue. So we'll just do a double half hitch and then reduce the tissue down to the bone. Once we have the reduction, we'll go ahead and pass point, squaring that knot up and getting that tension. Tie all 4 of these knots. We're not going to cut any sutures yet. Once we've tied all 4, we're going to retrieve 1 suture from each of those horizontal mattress configurations, and we're going to do an anterior lateral row anchor here. So we're dunking those sutures into the more lateral aspect of the greater tuberosity, compressing that tissue down to bone. Then we'll choose a second spot for a second lateral row anchor, thereby completing a double row suture bridge configuration. And you can see once we're finished, we've got excellent coaptation of rotator cuff to bone, excellent compression of the tissue to bone. And I like to view it from laterally, move it around, make sure there's no micromotion between the cuff and the tuberosity. As long as we have that, we can start early range of motion and early physical therapy. You can see secure fixation there. Thank you very much.